and welcome back to another episode of whatever the fuck this is called.
I think it's called the Rubin Report. And today we will be discussing conversations. We'll be having a very intense conversation on conversation and the importance of conversations.
I really think this is a great conversation to be having right now.
Yeah, and it's very that's exactly what I was going to say. It's a very important conversation because what's happening on college campuses right now.
Yeah, so I think hyperthyroidism is bad, and I want you guys to change my mind. It
helps me keep my weight down, which is a definite positive side effect.
It helps keep my eyes open.
It allows me to stay a healthy weight and at the same time overeat. So, which is fantastic.
Yeah. And well, you're sure it's not the meth that's supporting that habit. It's probably a combination thereof. So let's get right into the meat of hyperthyroidism. As you folks may recall, we did a comprehensive overview of hypothyroidism when last we met. So let's talk about the other side of the spectrum, that is hyperthyroidism. So perhaps starting with a clinical vignette. There's a gentleman. He's in his he tells you he's in his mid-20s, but in fact he's in his late 20s, approaching 30. He presents to your clinic disheveled, again sort of malodorous, poorly kempt. And he's been complaining of just profuse sweating, heat intolerance, more pronounced anxiety, and interestingly enough, a goiter or a swelling in his throat. Now he says, Doc. He says, Doc, I think I have acquired cretinism, and you sort of shake your head and you're like, what? That doesn't make any sense. And the patient becomes vaguely agitated as well. So you're worried about this gentleman. So you say, you know what? Let's do the full workup. Please proceed to exam room 3. We're gonna start ordering some tests here. So to start, you send in your med student, the lovely listener. Why don't we start with what sort of focused physical exam the medical student might consider, or the intern might consider, in working up this complaint?
Right. So some general signs that you would be looking for. Well, we noticed the goiter. Hair thinning is another aspect we'll see. Lid lag and retraction as well. I think this is due to increased adrenergic tone, but I think you get the Graves ophthalmopathy in about a quarter of the patients. And just as a side note, it's typically not something that would improve with treatment, but you're going to see it on pretty much every question stem. As soon as you see somebody with bulging eyes, just think hyperthyroidism, even though clinically it's really not as relevant.
Graves specifically, and I guess it's referred to as, some people will call it exophthalmos.
Yeah.
But it is a fairly specific marker of Graves with other symptoms. Yeah.
Right. Another kind of rare marker, but a common one on question stems, is pretibial myxedema. Again, quite rare. I think it's something like 2% of patients with Graves. And it's basically non-pitting edema over the shins with peau d'orange. Another sign we'll be looking for is palmar erythema. Some cardiovascular signs will be tachycardia, and especially in the older population, atrial fibrillation. And from the neuro perspective, you may notice a fine tremor as well. So particularly with the cardiovascular and neurological signs, you're thinking of somebody that's revved up. They're fired up, and they're in hyper overdrive. And as we saw in the clinical vignette. Symptoms that we would be anticipating as part of the revved up paradigm is weight loss with the catabolism, increased appetite to make up for the catabolism, heat intolerance. They might sense the atrial fibrillation with the palpitations. They might have the vague fatigue, sweating, possibly diarrhea as well. The menstrual changes, as we mentioned earlier, oligomenorrhea. And there's some neuropsych effects as well. Your patient will likely be pissed off about everything that's going on. They'll be irritable. They might be laughing. They might be crying due to their emotional lability. And they may be discussing that they have figured out the equation to the universe and they'll be beamed up in a spaceship due to their psychosis. So those are some general signs as well as symptoms in hyperthyroidism.
Excellent. Very, very clear. Very clear indeed. These signs and symptoms will have been elicited on your physical exam. Just pointing out that in an OSCE scenario, ensuring that you're appropriately palpating the thyroid, so practicing that a little bit, and be aware that there's likely a cup in the room with a bit of water in it. So ask the patient to swallow water, which is important to be able to palpate those lower lobes. You might consider listening for a bruit over the thyroid as well. Practically speaking, this is, I would comment, fairly low yield because thyroid is so amenable to ultrasound. But anyhow, bear that in mind for your OSCE scenario.
Maybe you can do it just as a gag to get them to drink your pee or something.
Yeah. Just have fun with it.
A little goof, you know.
Yeah, just be silly with it. Have a goof, have a spoof, and hope that your presiding evaluator has a sense of humor. Okay. So that was important, very important. Moving on. So the medical student return. You're worried about this gentleman, but you want him out of your urgent care because he's just stinking up the whole place. So the medical student, the intern, returns to your desk, and you're doing some Sudoku or whatever, and he or she provides the one-liner. So you start to pimp them. You say, "Okay, well, we're suspicious about this gentleman's goiter, his heat intolerance, his weight loss, his some disordered thinking." It's sounding a whole lot like hyperthyroidism. My goodness. So what sort of investigations do we want to initiate here to tease out hyperthyroidism and potentially its cause?
So in terms of labs, we'll be doing classic TSH. You might as well throw in a little T4 in there in the meantime as well. I think the main thing that you will be looking for with these lab values is TSH is low, while the thyroid hormones T4 is going to be high. So there's an overproduction or oversecretion of the thyroid hormone, which is going to have a negative feedback effect, resulting in low TSH.
I would also consider a thyroid scintigraphy or a gamma scan.
A thyroid.
A gamma
thyroid
scan
man.
Sounds like a good idea.
A gamma scan man for the thyroid. Yeah, that's definitely an option.
Yeah. Oh, and
distinguish this entity from thyroiditis.
Yeah, and we might be jumping the gun a little bit there with the scintigraphy or however you pronounce it. Just as a side note here, given how pedantic we were on the hypothyroidism lecture, if you're thinking that this is a central cause of hyperthyroidism,